Our next speaker is Glen Peterson. He'll be speaking to us about common emergencies in blood cancer, for which he is, at least here at university, our resident expert on this. Glen is a nurse practitioner and associate professor in the School of Medicine, practicing at University of Colorado in our Blood Disorders and Cellular Therapies program. He obtained his undergraduate degree in nursing from South Dakota State University and his acute care NP degree from Rush University in Chicago, and then his doctorate of nursing practice from the University of Colorado. Whew, that's a mouthful. Glen is the co-director of the Blood Disorders Center APP program and the clinical director of our APP Education and Quality program. And he also works with our CU Innovation Center, focusing on at-home care projects and research. So please join me in welcoming Glen.
Thanks, Meredith. So common emergencies in blood cancers. So as Meredith said, I've talked a lot about oncologic emergencies, kind of a thing I do quite a bit. And it's kind of gotten to the point where people kind of make fun of me about it. So I was sitting by one of our clinic nurses yesterday and I was like, "Hey, Maria, are you gonna come to the blood cancer boot camp tomorrow?" And she's like, "Glen, I've heard your onc emergency talk like 8 times already." And so I was like, "Oh, great." So maybe people are getting bored with it. I'm not sure, but I try to mix it up a little bit. I think oncologic emergencies, it's a big deal with our patients, and I think that, there's always new things coming up that I think are, out of the ordinary. There may be things that we don't see all the time that I think it's good to talk about and be aware of. But the fact of the matter is, and it's not going to go away, there's complications, emergencies with oncology patients that are induced by their disease and their treatment. And, I think some of the most important things we do, we can talk about all of the new therapies, the immunotherapies, the whatever kind of fancy new drug there is out there. But if we can't handle the basic management of patients at the bedside clinically, then I think, all of that doesn't matter, because, you have to treat emergencies, treat complications, deal with emergencies to make sure that patient can continue on therapy or get to their next therapy, or even just get to the next hours or days. So anyway, so I'll kind of keep talking about onc emergencies unless you guys just tell me you've got them all figured out and where there's no new complications or emergencies. So our objectives will identify blood cancer patients at risk for complications during treatment. We'll recognize and diagnose common complications in blood cancers. And again, I'm only going to talk about a handful of these. There's dozens of oncologic emergencies or complications related to the treatments we provide. We'll learn to appropriately assess, triage, and treat blood cancer patients affected by complications from their disease and treatment. So, we think about patients, upon presentation. So all of our patients come to us with a disease that we have to deal with. And I think our patients fall into 3 buckets, really, that are very important. The first one is clinical stability. So we, as providers, nurses, pharmacists, doctors, whoever is taking care of this patient, we have to make sure that we maintain clinical stability as the main objective, right? Because without clinical stability, we can't move on to the next phases or kind of, buckets that we put patients in, which is diagnosis and treatment. In regard to clinical stability, there are a lot of disease-specific complications that come up. You think about your leukemia patients. I always think of the big 4 complications we think about in a newly diagnosed acute leukemia patient. You have sepsis, or major infectious complications. You have DIC, Tumorlysis Syndrome, and then hyperleukocytosis leading to leukastasis. So those are kind of the big kind of things that we think about. And I always like to kind of try to simplify things. I'm kind of a simple-minded person, and I like to think about things in a simple way so that it makes sense and that everybody can understand it and remember it. So I always think about, what are the few big things I need to know about a leukemia patient when they roll through the door at 2:00 in the morning and I have to deal with them? or what are the big things that a lymphoma or a myeloma patient run across that I need to deal with and I need to know to get them to the next day. And so for leukemia, those are the big four. I added differentiation, which I'll talk about during this talk, because, there are some therapies that we use that are a little bit sometimes down the line for some of these patients that can cause differentiation and a syndrome along with it that can cause major complications. For our lymphoma patients, there's a variety of complications that these patients come across. You think about Tumorlysis Syndrome, significant pleural effusion, spinal cord compressions, increased intracranial pressure in those CNS lymphoma patients. So there's a little bit, I think, larger list for those patients. For our myeloma patients, really, if you know the acronym CRAB or CRABby, you can take care of any myeloma patient from the start, right? Thinking about their hypercalcemia, their renal insufficiency, anemia, and then broken bones. In some of the downstream, complications related to those. And then infections, myeloma patients are kind of a disaster in regard to the risk of infectious complications due to their immune paresis from their disease. All right, so in regard to the diagnosis, Meredith talked a lot about this, but you have your kind of basic things that you do for the majority of patients. Again, the first and foremost thing that you have to do is assess your patients well. Do a good review of systems, good physical exam. This is like the fourth time now that we've talked about this during our boot camp conversations, but it is the most important thing we do. And I think it's important to remember some of the most basic things that all of us do are the very most important things that we do. And then we send blood, we get bone marrow, we get tissue biopsies. Sometimes lumbar punctures are needed to assess CSF, and then imaging. And all of this in combination not only gets the diagnosis, but it helps us prognosticate, give a prognosis to these patients. And then we move forward with treatment. And there are a variety of different treatments, as you've heard in some of our prior talks, depending on what the disease is, what their comorbidities are. We have a lot of options now, which is a great thing. But there are some things that we need to think about before we start treatment, such as assessing organ function. That may be blood work, it may be an echocardiogram, an EKG, whatever that may be. Thinking about how we're going to administer this chemotherapy. The nurses are like, hey, Glenn, I'm giving like multiple anthracyclines via continuous infusion here, and you totally forgot to put a line in this patient. I'm not very comfortable with that. So let's get a PICC line in. Fertility, thinking about in our young patients, in their childbearing years, how important it is to think about fertility. We go through all these treatments and then we've, taken away a portion of their life. So thinking about fertility before we start treatment is very important. Leukopheresis, or cytoreduction in some of our patients who have hyperleukocytosis. We'll talk a lot more about that. But, just thinking about, what do I have to do to get the patient ready for treatment? I think is a very important part that sometimes you can miss and or skip portions of it that are very important. All right. So again, kind of like Meredith, I like these case studies, and these are real life case studies, or at least a version of the real life case study. So this is a 68-year-old male who was admitted to initiate R-EPOCH chemotherapy for bulky diffuse large B-cell lymphoma. And about 12 hours after starting rituximab in chemotherapy, the patient complained of decreased urine output, peripheral edema, perioral numbness, and chest pressure. The RN called the APP to assess the patient. So you can see before the patient, before we started chemotherapy, you can see the patient's labs are not quite normal. The creatinine's already elevated, uric acid's high, LDH is up, phos is on the high side, and calcium's starting to drop. That's a pretty normal EKG overall. This is the patient's PET CT scan. So you can see all those black areas there. That's all tumor. So very large bulky tumor here, lighting up very highly on the PET CT scan. And so the APP goes to assess the patient, and the blood pressure is stable, but the other vital signs are, moving in the wrong direction. So the patient's starting to become a bit hypoxic. They have sinus tachycardia, coarse lung sounds. They already have some edema, some abdominal tenderness, and you can feel that mass still in the abdomen. Patient has a positive Trousseau sign, and it's not common for us to do a Trousseau test, right? So you pump up the blood pressure cuff on their arm and their hand curves in. This is a sign of tetany. But a good time to do that is when you see a calcium of 5.9. So this patient had a rapid decrease in the calcium because the phosphorus was going up. And the phosphorus binds calcium and lowers calcium. You can see the creatinine is going off very quickly. Potassium went to almost 7. Uric acid 14, and LDH 4,000. So this is a situation that you do not want to see with a brand new bulky diffuse large B-cell lymphoma patient, but we should all expect it and anticipate it and kind of prepare for it. And you can see on this EKG, this is kind of the classic hyperkalemia signs of EKG changes and progression to a soon-to-be dysrhythmia. So you can see these T waves, tall tented T waves we've all learned about and heard about in school. And this patient is also losing the P waves. You can see the P waves are gone here. So this patient is pretty rapidly progressing to a point where they're going to have a major cardiac dysrhythmia. So this is Tumorlysis Syndrome. So this is a life-threatening condition that occurs after cellular destruction of rapidly growing tumors, and then the release of all those intracellular components, potassium, phosphorus, uric acid, and these in combination lead to renal dysfunction. So this typically occurs in the first several days of chemotherapy. You can see this within hours of the initiation of chemotherapy. And a few patients, kind of like this patient, they come in with signs of autotumorlysis syndrome. So they're already, their disease is replicating so fast that it's kind of dying off at the same time and releasing all those intracellular components. In some patients, especially those with a high white blood cell count, like our acute myeloid leukemia patients, you can get a cytokine release syndrome. So as when you start treatment, it causes a lot of cytokine release, and you can have all of the complications of cytokine release syndrome. So fluid retention, pulmonary edema, this whole SIRS multi-organ failure system. And we've definitely seen that happen in some patients when initiating therapy. In some of those patients, you need to really all of those patients, you should cytoreduce them before starting treatment to reduce the complications of tumor-lysis syndrome and other major complications. And we know that clinical tumor lysis may result in rapidly progressive renal failure, seizure, and cardiac dysrhythmia leading to death. Has anybody in this room seen a patient have severe tumor lysis syndrome to the point where they have a cardiac arrhythmia? We've seen it on the inpatient unit for sure. And it is definitely something we want to try to avoid. So there are risk factors for patients in anticipation of tumor lysis syndrome. So in regard to disease, of course, patients with high white blood cell counts, like those with acute myeloid leukemia, are very high risk for tumor lysis. Other acute leukemias, ALL, are at risk, not as high as AML. And then bulky lymphomas are another kind of disease-related risk factor. Patient factors, so again, bulky abdominal disease or bulky disease in general is a risk factor. Patients who are dehydrated, maybe have organ dysfunction like renal dysfunction, they're much higher risk for tumor lysis syndromes, or at least the complications of tumor lysis syndrome. Elevated lysis labs prior to starting therapy. So this is a big sign that the patient has just bulky disease. They're hyperproliferative. They're turning over cells. They're already kicking out intercellular components. And they are very high risk for tumor lysis. Of course, the treatment we give are biologic agents, chemotherapy, even steroids can cause tumor lysis syndrome. And then again, radiation therapy, and then again, those autotumor lysis patients, that some of which end up even on dialysis before you start treatment. So there's a difference between lab tumor lysis and clinical tumor lysis. Lab tumor lysis is just that. You have evidence of elevated potassium, uric acid, phosphorus, and a low calcium. And then clinical tumor lysis is when those electrolyte abnormalities cause end organ damage, like a seizure or renal failure, cardiac dysrhythmia. This is the Carroll Bishop grading classification of Tumorlysis Syndrome, which I can't say we pay a lot of attention to. We kind of just base everything on what the risk factors are and what the labs show us. So depending on the metabolic abnormality, you'll have certain clinical manifestations. So hyperkalemia, of course, is our number one worrisome electrolyte abnormality. And we always think about the heart with hyperkalemia is really, the thing that we need to monitor very closely. And kind of like our prior EKG, you can see that this, kind of the progression of how things go. You have these tinting of T waves, and then you start losing your P wave, and then you go into this sine wave, and then patients die of a cardiac arrest. And sometimes this can happen very quickly. Patients in the cardiac muscle, conduction of the cardiac muscle does not tolerate excessive potassium very well. Hyperphosphatemia. So, the combination of a high phosphorus binding to calcium, it basically creates bone. And so bone that circulates through the kidneys does not go well, and patients develop acute kidney injury. Hypocalcemia, again, in combination with the phosphorus is the major problem in regard to the kidneys, but hypocalcemia can lead to tetany, which is, definitely can be a serious condition, can lead to seizure activity. Hyperuricemia in itself can cause acute kidney injury. So how do we deal with this? This is one of the most important slides, I think, for hyperkalemia. Kind of the interventions also fall into three buckets. So, the first one is, if a patient is leaning towards cardiac arrhythmia, so their potassium is really creeping up there and you're at risk for this, they start to show EKG changes, you definitely need to stabilize the heart. So giving calcium gluconate is one way that you can stabilize the heart, stabilize the electrical conduction to the heart or within the heart. Shift potassium. So shift potassium back into the cell. So all this potassium has been kicked out of the cell. Now you got to shift it back into the cell to try to, again, protect the heart. So using drugs like sodium bicarbonate, insulin D50, albuterol, this can shift the potassium back into the cell. And then removing potassium is the most important thing eventually. Using drugs like Caxylate, Lokelma are very important to reduce the potassium, and then dialysis. And again, I think having a reasonably low threshold for dialysis is very, very important in those patients who are showing significant signs of tumorlysis syndrome, especially with the hyperkalemia. Hyperuricemia, we use allopurinol, so it decreases the production of uric acid, and then rasburicase. It's an enzyme that rapidly hydrolyzes uric acid in the blood. Of course, we give fluids for all of these electrolyte abnormalities, and think about dialysis for these patients, especially in those patients. We don't dialyze patients for hyperuricemia alone, but it's usually the combination of hyperkalemia, renal dysfunction, where we'll dialyze patients. Hyperphosphatemia, of course, there are some medications we can use, phosphate binders such as sevelamer, aluminum hydroxide, and calcium acetate. And the hypocalcemia, due to that phosphorus binding, we try not to give calcium if we can, just because it can induce more AKI. But in some patients who have any sign of tetany, we definitely want to give these patients calcium. So this is a rasburicase guideline that one of our speakers today, and I don't know where Lucy went now, but Lucy developed this guideline, one of our upcoming speakers. So this is a really great resource for us to kind of help us dose. There's Lucy talking about your guideline. So this just helps us be able to effectively dose rasburicase in the midst of hyperuricemia of tumorlysis syndrome. So our patient, so we repeated tumor lysis labs and a G6PD. So this G6PD thing, so rasburicase in patients who are G6P deficient can cause hemolysis and a methemoglobinemia. So we like to know eventually what the status of a patient's G6PD is. We don't hold therapy waiting for G6PD because it takes days to get back, but that is something that we do like to send. We gave this patient 10 units of regular insulin and an amp of D50. gave him Kexalate, a normal saline bolus, allopurinol, respiricase based on our guideline, sevelamer, calcium gluconate. Monitored this patient very closely on telemetry with very close monitoring of labs, which is very important, right? When somebody is at risk for tumorlysis syndrome, you don't just check them once a day or once every other day with their labs. Check them every 4 hours, every 6 hours, depending on their risk. ICU and renal teams were consulted for potential dialysis or transfer to the ICU. Fortunately, after all of these rapid interventions, the patient's potassium came back at 4.9, phosphorus down to 7.5, uric acid 8, and the creatinine was moving in the right direction. So we didn't require the ICU, didn't require dialysis, and the patient recovered and then had no issues upon subsequent cycles. I think that's an important thing too. Once a patient has tumor lysis, you get through the first cycle, they never have tumor lysis on subsequent cycles. At least in lymphoma patients. So the key points of TLS, so high-risk patients should be treated in the hospital due to risk of tumorlysis syndrome because they require very close monitoring and intervention. Give Rituxan at the end of chemotherapy. So this patient got Rituxan early on, which probably was a major factor in his tumorlysis. Allopurinol prior to chemotherapy, close monitoring again, IV fluids, and then acute management of electrolyte abnormalities. And then the other point, I guess, I talk about Rituxan, but in those patients, those other very high-risk group of patients, like our acute myeloid leukemia patients, you want to get their white blood cell count down before initiating therapy with whatever you choose, whether it be a less intensive or more intensive therapy. Okay. Case number 2. So this is a 67-year-old male with no past medical history who presents to the ED with back pain, bowel and bladder incontinence, leg weakness, and saddle anesthesia. The APP is called over to assess the patient in the emergency department. On exam, the patient has bilateral lower extremity weakness, decreased deep tendon reflexes and sensation, severe point tenderness in the lower spine. And you can see this patient's labs are pretty abnormal. So, we think about those crabby criteria. This patient has hypercalcemia. They have renal dysfunction, so an elevated creatinine. They're anemic. And then this patient has compression fractures and ends up having a spinal cord compression. So this is a myeloma patient, new diagnosis myeloma patient, which we see not uncommonly. These patients come in like this with broken bones, broken spine bones, leading to cord compression. So it's a very serious scenario. And so you can see that the lower spine, vertebral fracture causing a cord compression. And then this patient was, again, after the assessment by the APP, they realized this is a medical emergency. We need to get this patient decompressed as soon as possible. So called the spine surgeons, and they said, "Yep, let's get into the OR right away to save this person's legs." So went to surgery and had decompressive stabilization surgery. So this is a malignant spinal cord compression. So this occurs when a malignant disease or a pathologic vertebral fracture compresses the spinal cord or cauda equina nerves. It's the most common in metastatic solid tumor patients, but we see it all the time in our myeloma patients. And I've seen pretty devastating neurologic compromise in a number of patients related to this. Pain is the most common presenting symptom. And this is a very important thing. Anybody can report pain if you ask them about pain and you do a physical exam and push on their spine and find out that they have spine pain. So it's a pretty easy thing to define and act on. So depending on the level of the spine, the patient will have kind of correlating physical exam findings. The thing about patients that we deal with in the blood cancer world, it's different than solid tumor patients who have a kind of an adjacent spinal cord compression depending on where their primary tumor is. So if you have a head and neck cancer, they most often metastasize to the spine and the neck. If they're a lung cancer patient, they most often have spinal cord compression in the thoracic spine. Myeloma patients, it doesn't matter. So they could have a lumbar spine compression fracture and then have an impending one in their cervical spine also. So, it's kind of, and of course, the clinical syndrome is very important, but you have to anticipate more than what sometimes you see on exam also. So the management of spinal cord compression. So the aim is to alleviate pain and prevent permanent disability. Those are the two big things. Of course, it all starts, again, we harp on this all the time, with talking to the patient and doing a physical exam. Do they have pain? Do they have any neurologic impairment? And where is that? And what is the baseline? Because sometimes these patients change quickly. And you have to know, if you don't know your baseline, you don't really know what the change is. So again, that initial exam is very important. And then getting a diagnostic imaging. MRI is the test of choice. You always want to scan. So we have to, in myeloma patients, for example, we have to scan the entire spine. And so the entire spine is like, what, 5-6 hours of MRIs. So, but, to focus on and think about where's the pain? Where's their neurologic compromise? So if they have pain in the lumbar spine, have the radiologist scan the lumbar spine first to see if you can define and find that cord compression location so that we can act on it. And then you can always work in the rest of the spine later on. Of course, neurosurgical and radiation oncology consultation is really the first thing you do. Before you get MRI results, just call the neuroradiologists or the neurosurgeons and the radiation oncologists. And then interventions, again, surgery or procedural, and somebody who has spinal cord compression, you're going to have decompressive surgery, stabilization surgery. Some patients that just have pain without neurologic compromise, they can be cared for with vertebroplasty or kyphoplasty to decrease pain. Dexamethasone is our friend for any kind of spinal cord injury, radiation, and chemotherapy. Of course, we have to have definitive chemotherapy and definitive treatment for the underlying disease to take care of this in the long term. So our patient, a Foley was placed, gave an NS bolus, scans showed spinal cord compression. The neurosurgeons and radiation oncology teams were consulted in the emergency department. Steroids were given, pretty high dose dexamethasone. Stabilization surgery completed. And then they were planning for post-surgical radiation treatment. So with the Blood Disorders Center, we co-managed this patient, started them on chemotherapy, Zometa, antibiotic prophylaxis. And then the pain was controlled. The patient was sent to acute rehab, had improving strength, got near baseline, and they were discharged at day 24. But what an incident and what a burden on this patient to have a spinal cord compression and have to sit in the hospital for an extra 3 or 4 weeks, because of this. All right, so the key points of spinal cord compression. So this occurs with solid tumor metastases and blood cancers. Again, those myeloma patients are the ones at most risk in our world. May cause severe pain, which is the most common thing, and permanent disability. So we need to assess these patients thoroughly. Immediate neurosurgical and radiation oncology consultation, steroids, and then treat the disease as soon as possible. All right, our next case, number 3. So 66-year-old male with a history of diabetes, hypertension, obesity, comes into the emergency room with fatigue, weakness, shortness of breath, dizziness, headache, and bruising. So the blood cancer APP was called to assess the patient in the emergency department due to concern for acute leukemia. On exam, the patient was ill appearing, pale, tachypnic, a diffuse petechiae and ecchymosis, and was slow to respond, only oriented ×2. Patient was transferred from the emergency department to the MICU with the blood cancer team consulting. So some of the diagnostic information. So the patient was febrile. You can see his vital signs are not normal, breathing fast, tachycardic, blood pressure was maintaining. O2 sat, though, was only 78% on room air. The patient required 5 liters of oxygen just to get him to 90%. Had diffuse reticular opacities with a pneumonia also. You can see the white blood cell count, 175,000. With a large percentage of blasts. Hemoglobin was down to 5, platelets were 8, creatinine is elevated, uric acid. This patient has signs of Tumorlysis Syndrome at this point. And a bone marrow biopsy was done, and this is consistent with a monocytic acute myeloid leukemia. So this is hyperleukocytosis and leukastasis. So this is something that, unless you're working with a lot of acute leukemics or you're in a center that takes and cares for a lot of acute leukemics, you never see it. But it is something that is, kind of a high impact condition that you need to definitely act on immediately, and you can make a difference. You can save patients' lives by treating this appropriately. So hyperleukocytosis, patients with proliferative acute myeloid leukemia may present with extremely high white blood cell counts, and they're more likely to have complications from tumorlysis syndrome, DIC, and hyperviscosity. So leukastasis is a result of this hyperviscosity of hyperleukocytosis. And it occurs more frequently in patients with acute myeloid leukemia, less commonly in ALL, and it's very rare in chronic leukemias and lymphomas, but not impossible. Leukastasis may result in tissue ischemia, infarcts, and thromboembolic events. These events may manifest as mental status changes or stroke-like symptoms, respiratory insufficiency, priapism, or extremity compartment syndrome. So leukodepletion. So this is important. There's more than one way to leukodeplete a patient. Just bring the white blood cell count down. So we start off with hydroxyurea. Really, anytime a patient comes in with a concern for acute leukemia, we don't know the type. We typically start hydroxyurea, and you typically know within a fairly short period of time. It's almost somewhat diagnostic. If they start to respond to hydroxyurea, they probably don't have ALL, because ALL doesn't respond well to hydroxyurea. So it's really only effective in myeloid leukemias. Steroids are much more effective in ALL, for example. Leukopheresis. So this is kind of the second part of how we leukodeplete or cytoreduce these patients. So we use an apheresis machine to basically just take off white blood cells. It's very similar to what we use for collecting stem cells on patients. This typically, so one run typically reduces the blast percentage by 30 to 60%. And sometimes patients' symptoms will improve even after one run. So, if a patient is altered or if they have respiratory compromise, some of that can improve. Oftentimes even DIC starts to settle down once you start reducing the white blood cell count. Sometimes this is repeated. I would say in our very proliferative acute myeloid leukemia patients, we might do 2 runs, maybe even 3 in some patients. And again, it's not typically indicated for patients with chronic leukemias, except in rare cases where the patient's white blood cell count is in excess of 1 million, which is pretty unusual to see. And then, of course, initiating AML treatment, definitive treatment for their underlying cause of their hyperleukocytosis is very important. So we've recently had this discussion, and actually kind of a case review recently that we did, is leukopheresis helpful? So, there is not a lot of evidence to say that leukopheresis is helpful. There's studies that say it doesn't really improve outcomes, early death, these kind of things. I would say that clinically, we're certainly not at a point where we're going to say we're not going to do leukopheresis anymore. I think there are groups of patients that do benefit from leukopheresis, especially those patients who you start on hydroxyurea, for example, that don't respond very well. They're just proliferating so fast. They're building leukemia like crazy. And, cytoreduction with hydroxyurea alone does not do it. So that would be a scenario. And then those patients that you want to get to treatment safely and quickly. So patients that you want to induce them with standard 7+3 induction chemotherapy. It's challenging to induce a patient with 150,000 white cells with induction chemotherapy. You're kind of asking for trouble. Also patients that may be induced with lower intensity regimens like venetoclax-based regimens. There's a warning with the use of venetoclax that you want to reduce the white blood cell count down to less than 25,000 due to risk of tumorlysis syndrome. And it's not just tumorlysis syndrome, DIC and other complications that occur if we initiate therapy with a very high white blood cell count. And we've done that. And we've seen patients end up in the ICU in those kind of scenarios. So what about acute promyelocytic leukemia? So APL is an interesting form of acute myeloid leukemia that is characterized by this 15-17 translocation, and much different than any other acute myeloid leukemia. These patients come in with DIC as a major complication. And a few of these patients, it's very rare to see a hyperproliferative acute promyelocytic leukemia patient. They usually have very low white blood cell count, and but there are a few that come in with pretty hyperproliferative. And trying to leukopherese those patients is generally probably not a good idea. If you leukopherese a patient who has acute promyelocytic leukemia, you can induce massive and severe DIC, and patients can die of it. They have intracerebral bleeds, GI bleeds, pulmonary hemorrhage, and can die of that complication. So in general, and kind of based on kind of a variety of recommendations, we think that it's probably in almost all cases not a good idea to pherese these patients. And it's important, and that's why we rush in a new acute leukemic who comes in with DIC. We want to know what their PML-RARA status is. We want to know if they have APL, because if we have to make a decision on leukopheresis, we want to do it quickly. So that weighs into our discussion. But it's, in one study here, half the patients with APL who received leukopheresis died. So, so it's definitely something we try to avoid. So our patient, we started him on hydroxyurea, 2 grams, 3 times a day. So it's kind of a typical dose for a hyperproliferative AML patient, sometimes 4 times a day in that dose. Leukopheresis was done twice, close lab monitoring, electrolyte correction, basically just tumor lysis management. We consulted the renal team. We started the patient on CVVH, got the white blood cell count down to 25,000. The patient was started on azacitidine and venetoclax. Sorry about the misspelled azacitidine there. And again, Tumorlysis Syndrome and DIC were managed. The patient eventually recovered, came off dialysis, and was transferred out of the ICU to the BMT floor. And on the day 28 bone marrow biopsy, the patient was in remission. So this is something that we see not real uncommonly. So leukastasis, key points: initiate leukodepletion immediately, have signs of leukastasis, such as hypoxia, respiratory failure, altered mental status, priapism, tissue ischemia. Leukopheresis may be useful in cases of refractory hyperleukocytosis or to hasten initiation of treatment, like we discussed. Manage TLS and DIC aggressively. Initiate treatment ASAP. And we know that the problems with these patients don't go away, whether it be TLS, DIC, whatever. None of it goes away without treatment. All right, this is our last case. I, like Heather, sometimes go beyond my allotted time, so I'll try to get through this one before your lunch break. All right, so this is a 73-year-old male with hypertension, type 2 diabetes, who's transferred to UCH with low blood counts and 50% blasts in the blood. Bone marrow biopsy was completed and revealed this MLL gene rearrangement with their acute myeloid leukemia. The patient failed 2 cycles of azacitidine and venetoclax and was transitioned to a study with this menin inhibitor. And the plan was to get the patient in remission and proceed to an allo stem cell transplant. So 4 days after starting the trial, the patient's caregiver called to report fever of 101.4, shortness of breath, and significant weakness. Caregiver was instructed to call 911 and bring the patient to the emergency room as soon as possible. So the BMT APP saw the patient in the ED. I think this was Meredith, probably working an overnight, and noted significant shortness of breath, work of breathing, progressive hypoxia. The patient was on 12 liters of oxygen. Again, had a fever, a rapidly rising creatinine. So the creatinine went from 1 to 2.5 in just a very short period of time, and then had worsening pulmonary infiltrates on X-ray. Patient was transferred to the MICU given the worsening pulmonary failure. And so some of the data on this patient, you can see when they showed up in the ER, their vital signs were nowhere near being stable. Patient is on 12 liters of oxygen, or got put on 12 liters of oxygen. Had diffuse reticular opacities with pulmonary edema. White blood cell count shot up. Earlier in the day, the white count was like 9. Blasts were 60%. Other blood counts look bad. The creatinine's going up, uric acid, phosphorus, potassium. All of this was starting to go in the wrong direction. This is the patient's chest imaging. So the first day that they started the trial, and then by the 4th day, you can see the pretty significant pulmonary infiltrates here. It's a CT view of it. So this is differentiation syndrome. So this is a rare but very important complication that sometimes sneaks its way under the radar a little bit. So these are the kind of things that I think it's important to talk about, because when you see it, nobody knows what to do, because it's been a year since you saw it before. So I think it's good to kind of keep on our mind. So differentiation syndrome. So this is, the classic disease that we see differentiation syndrome with is acute promyelocytic leukemia. 2 major, conditions or complications associated with APL, or DIC and differentiation syndrome. So with APL, there's probably somewhere around a 30% chance of differentiation syndrome when you start ATRA or arsenic. Both drugs induce differentiation. In patients with non-APL acute myeloid leukemia, IDH inhibitors, FLT inhibitors, menin inhibitors cause differentiation syndrome. And these are all, not the newest generation drugs, but newer generation. Menin inhibitors are new. And there are even case reports with hypomethylators like azacitidine. So there's a slightly higher incidence of differentiation syndrome with our IDH1 inhibitor, ivosidenib, compared to IDH2 inacidinib. And onset is later compared to other drugs that we use for APL, for example. Menin inhibitors, kind of in the initial trial with the menin inhibitor, differentiation syndrome occurred in about 16% of patients. In FLT3 is a rare, but can happen in FLT3 inhibitors. Gilteritinib, about 3% of patients. So the mechanism is not completely understood, but it's likely kind of a similar cytokine-mediated mechanism for all of these drugs. It's characterized by unexplained fever, leukocytosis, weight gain, edema, dyspnea, hypoxia with pulmonary infiltrates, pleural pericardial effusion, hypotension, and acute renal failure. It's challenging clinically because it does mimic other things, like heart failure, infectious complications, and so on. Risk factors for severe differentiation syndrome are a white blood cell count over 10, and then acute renal insufficiency. Mortality has been high in patients with acute promyelocytic leukemia, but I think now with some of the interventions of steroids early on in the treatment, or at the time of initiation of treatment, we still see it, but in less severe forms. APL is interesting. You can see different, some of these like IDH inhibitors, it takes a little bit of time to cause differentiation syndrome. With APL, I've seen 1 dose of ATRA cause major differentiation syndrome. So it's quite remarkable how active these drugs are and how much cytokine they can produce through their mechanism of action. So this is kind of the typical mechanism of action. So you have your AML blast and you initiate treatment with whatever drug it is that causes differentiation. And then you have this major kind of release of cytokines, this cytokine storm. And then you have adhesion molecules are upregulated. So these blasts stick to the endothelium, and then they make their way through the endothelium and bring fluid and so on with it, causing pulmonary edema and kind of this whole kind of constellation of symptoms of fever, leukocytosis, fluid overload, pulmonary failure, and in some cases, multi-organ failure. I always think these are kind of interesting slides. This is a gilteritinib FLT3 inhibitor that's showing how these cells differentiate over a period of time. So you can see these are normal blasts, and you can start to see these little guys differentiating all throughout here. And this again can happen pretty quickly. So again, these big blasts, you can start to see some nucleolus changes to the point where they actually become, lobed and differentiate into more mature cells. So It's quite remarkable. For IDH inhibitors, this is kind of what happens and what we see. So you can see as the neutrophils rise, a inverse effect of the blasts, and that's the aim of these drugs. You can see that as these neutrophils rise, these are the points when the patient. So then in this kind of first part of the treatment, you can see this is where the patient started getting some differentiation syndrome. And received dexamethasone, even required hydroxyurea in a couple of situations here to reduce the white blood cell count. So, does differentiation syndrome improve response? So I think that's kind of a big question, right? If you get differentiation syndrome, kind of like we think about CRS or neurotoxicity, people think, oh gosh, maybe this means that it's just working so much better and I'm going to have a better response. Well, for differentiation syndrome, it doesn't seem to be the case. Actually, they have worse outcomes in patients who have significant differentiation syndrome, at least in patients who receive IDH inhibitors. All right, so the management. So are these all the same? The mechanism is pretty much the same. And so really all of these are kind of treated the same. There is some guidance from the NCCN on acute promyelocytic leukemia. And it's basically, at the first sign of significant differentiation syndrome, we give steroids. So dexamethasone 10 BID is the typical treatment for differentiation syndrome. Patients who, have an elevated white blood cell count, sometimes we add additional therapy, such as hydroxyurea, sometimes chemotherapy, like anthracyclines or gemtuzumab. In general, I think with the protocols we use for, our Lococo regimens and so on for acute promyelocytic leukemia, we prophylax these patients these days at the start of atro-therapy with prednisone. I think this has made a pretty dramatic difference in our outcomes related to in the severity and outcomes of differentiation syndrome and acute promyelocytic leukemia. If the patient, on prophylaxis develops significant differentiation syndrome, then we change to dexamethasone. There's some tapers that we do, sometimes switch back to prednisone if the patient seems to be at continued risk, but is not actively having differentiation syndrome. Again, if those patients exceed 10,000 on their white blood cell count in the midst of differentiation syndrome, we use hydroxyurea. Sometimes, again, we have to use chemotherapy like gemtuzumab or anthracycline. It's not common, especially in those patients that are low risk to begin with, who come in with a very low white blood cell count, but it can happen. And then antibiotic prophylaxis. So again, with these patients receiving a lot of steroids, we oftentimes will use anidulafungin. You can use Cresemba. We want to be careful about QT, obviously, in patients receiving arsenic. Acyclovir, Bactrim may be used, and then antibacterial prophylaxis is oftentimes required as these patients drop their blood counts. So non-APL differentiation syndrome management. So these are like IDH inhibitors, FLT3 inhibitors, menin inhibitors, kind of the same concept. They present similarly with all of the signs of differentiation syndrome, treated with dexamethasone, sometimes escalating doses of dexamethasone, depending on how severe it is. And then if they're responding, you can start to taper steroids. Again, additional drugs can be used in patients who develop a leukocytosis. The one thing to remember that I think is important, so when we think about IDH inhibitor induced differentiation syndrome, these drugs have a very long half-life. So just stopping the drug alone, which is sometimes what we think, if they have severe differentiation syndrome, we stop the drug, interrupt the therapy for a period of time until things clinically settle down. But stopping the drug with these IDH inhibitors doesn't fix the problem. So you do have to be aggressive with the use of steroids for these patients. So our patient, last couple slides, I know I'm keeping you away from your lunch. So this patient was started on dexamethasone, 10 milligrams IV Q12 hours with a plan to start hydroxyurea if the white blood cell count exceeded 15. Lasix as needed, tumorlysis, DIC monitoring, antibiotic treatment for pneumonia and the possibility of infection. Remember, these conditions mimic infectious complications. We can't ignore the possibility of infection in an acute myeloid leukemia patient who is vastly myelosuppressed. The study drug was continued. The patient started to improve with less hypoxia. A few days later, developed signs of tumorlysis syndrome and worsening hypoxia and differentiation syndrome with a rising white blood cell count, worsening pulmonary infiltrates. And at that time, the study drug was held appropriately and hydroxyurea was increased. Patient responded to interventions, had resolution of hypoxia, tumorlysis syndrome resolved. Steroids were able to be tapered off over a couple of weeks. Hydroxyurea was discontinued and as the leukocytosis resolved, and then the study drug was resumed with no recurrence of differentiation syndrome. And a bone marrow biopsy was completed. Another happy story. The patient was in a CR and I'm sure got to a stem cell transplant and is cured. So the key points with differentiation syndrome, it's common in APL, less common in non-APL AMLs. Characterized by fever, leukocytosis, fluid retention, hypoxia, pulmonary infiltrates, hypotension, and acute renal failure. It's caused by ATRA, arsenic, IDH inhibitors, FLT inhibitors, menin inhibitors, and maybe others. Treated with steroids and cytoreduction. Stop the offending agent if the differentiation syndrome is severe, especially with pulmonary failure. And prophylactic administration of steroids to prevent differentiation syndrome is important. All right, so that's it. Any questions? Yes, Heather. That's a good question. That's a really good question. I kind of thought you might ask me that, but I don't know the answer. I think, yeah, right. Yeah, no, you'd think maybe outside. I mean, I think certainly in general, we have a pretty effective strategy that is maybe not ultra immunosuppressive, with the use of steroids. And it seems to work in almost all patients. But yeah, you wonder about, is there a target like we have, for other, like in our CAR T world with TOSI and others that we could use that would be effective, I the incidence is not nil, but it's not like CRS, for example, where 70-80% of the patients get some form of CRS or whatever. But yeah.
Hold on, people are having trouble hearing on.
Is there a common median onset of differentiation syndrome in like ADH inhibitors?
Yeah, so IDH is like 30 days. They have that real long half-life, and I think it just takes longer. We've definitely seen it sooner than that. I know we've seen patients probably within the first couple of weeks have differentiation syndrome on IDH inhibitors. Of course, ATRA, arsenic, the median is like 10 days, but we see it sooner than that for sure. I mean, like I said, one dose and this, patients kind of come undone with differentiation syndrome on a few cases. So.
Oh yeah, the first question that I asked was if there were common cytokines between differentiation syndrome and cytokine release syndrome, given the capillary leak overlap.
Anybody else out there?
All right.
Thanks, Glenn.
Yeah. All right.
Awesome.